And welcome to everyone who is tuning in. And perfect. All right. So good morning, good afternoon, good evening. I would like to take this opportunity to welcome everyone. I am Dr. Akwi Asambang. I am the co-founder and board president of the Pan-African Organization for Health, Education, and Research. I am very excited, as always, to be here. Wherever you are, it's either early in the morning, it's late in the afternoon, or it's early in the evening or late at night. This is, part of our POHAIR breast cancer awareness series. And for some of you who have joined us early on, as we had explained before, we have this in 3 segments. The first segment was a conversation with Dr. Catherine Mwaba, focused sort of on the medical oncology aspect in terms of chemotherapy, radiotherapy, breast cancer risks, et cetera. Our second session today is focused on, patient advocacy. And we have, Dr. Marilynn Omondi, who will, go over that. She'll have a conversation with our POHAIR scholar, Anya, Avis, Nowbuth. And, if you're in the webinar, please feel free to ask any questions. Once someone gets diagnosed with cancer, it's really an emotional toll. It's a mental toll. There's, social aspects. There's so many questions a person may have. It's not only about, whether it's the drugs we're giving them for the treatment or whether it's a surgery we're doing. I think there's other aspects that include resources and just trying to advocate for the patient. So today, Dr. Omondi will sort of, focus on that conversation and also, share with us her experience at her institution. And then the next session that will be our last session for the month would be our breast surgical oncologist, Dr. Miriam Mutebi, and we'll talk about that later. So for now, the way this works, if you're live on Facebook, please feel free to type your questions in the chat box in the comment section. If you're in the webinar, type your questions in the Q&A or in the chat box, and Anya will go ahead and get to you. So a little bit about our moderator, whom by now I think everyone knows pretty well. Is our scholar, Anya Avis Nowbuth, our rockstar scholar, who is also, once again, bragging, feeling like a proud mama here, a Millennium Fellow, which is a program with the United Nations, amongst a billion other things that she's done. Anya, I will hand things over to you. And, this is, you're in charge. I'm in the background. If there's any issues to the audience, I'll just pop in and provide some assistance. But once again, good morning, good afternoon, good evening. We are absolutely thrilled to welcome you and absolutely grateful for the time Dr. Omondi is going to be sharing with us today. All right, Anya, over to you.
Good afternoon, good morning, good evening, everyone. Thank you so much, Dr. Asambang, for the generous and the kind introduction. So thank you so much, Dr. Omondi, for taking time out of your Saturday afternoon to also be present and help us understand and educate the fellow students as well as the general public on what it means to be a patient advocate or for advocacy for breast cancer. So I'll start with a very simple question. Dr. Omondi.
Hello, good afternoon, good morning to everybody. Thank you, Anya.
So Dr. Omondi, can you tell us a little bit about your career path as a breast surgeon, or tell us a little bit about yourself, how you got interested in it and what your thoughts are about breast cancer, etc.
Okay, I got interested in surgery actually in my final year of medical school. And in my country where we train, so right after that, we do internship of 1 year. And so I think that solidified my interest in surgery. However, I think my interest in breast cancer and, so to speak, breast disease that led me towards the path of being a breast surgeon was cemented more in my final year of training as a resident in general surgery. And this came about by in my country where I saw women come in with late presentations of cancers. We had very few breast surgeons. And because Africa, well, generally sub-Saharan Africa, there's still quite a bit of patriarchy that goes on. And so you find a lot of the women are not able to speak about women's health without, talking back to the male in the society to give them leadership. And so I felt as a female in surgery, I think just doing breast surgery, I would be able to advocate for women's health just beyond getting them access to healthcare, somebody that they would be more comfortable talking to. And I felt that was where I would be able to make a difference.
That's so true, and that's a very interesting observation, because I feel that even in Zambia, it might be a very similar environment when it comes to women and seeking healthcare. So what does it mean to be a breast cancer advocate, and why is it important?
So what I realized is a lot of the time, the women will come in, they'll see a doctor who will probably refer them to the breast specialist. They get a diagnosis made, and then they just, run off the meal through the system. But then I sat back and I asked myself, what happens beyond the breast cancer diagnosis? And we have different challenges actually in sub-Saharan Africa. In the Western world, I suppose you could say they're more enlightened, and the system will probably educate the women as they come along for their treatment. However, in sub-Saharan Africa and in my country, Kenya, we have challenges that we need to surmount to be able to make these women comfortable beyond just the diagnosis. We're talking about women being the homemakers. We're talking about women who, a lot of them will still look up to the person who's the patriarch in the family. We're talking about socioeconomic status. We're talking about beliefs, Some women will think, this is, witchcraft, or I need to get prayed for. But most of all, actually, is that most women will be scared to face the diagnosis because they're scared about leaving their families and who will take care of their families. And so then I realized once we become patient advocates on that front, when I speak to a lady and I say, oh, hey, well, so we have breast cancer, but it doesn't mean this is the end. Then if I'm able to work with her and advocate for her within the system, that it doesn't mean you'll not be able to take care of your family. Just because you don't have finances doesn't mean that you're not able to walk this path. Just because, maybe because of the treatment, you might lose your hair, you might, lose a breast. It doesn't mean just because you don't have money that you might not have access to, at the end of the treatment, maybe a wig or a prosthesis. We can be able to link them up to support groups. And I realized that actually made a turnaround in clinical adherence in my country, in Kenya. And so patient advocacy actually just comes in beyond the cancer diagnosis. How can you work with these women, make them comfortable in their work? How do you make it a less daunting task for them to face? Because remember, when they go back home, they're still just the same lady who left before they found their diagnosis. And so if you're able to do that and make them a little bit more comfortable, they're most likely to adhere to their clinical care with less bumps on the highway, so to speak.
Yeah, that's very true. And I think that's what also is such an important aspect as being someone in the healthcare field, is this power almost that you have to support and advocate for your patients to get healthcare that is quality, even though there is not necessarily funding available. So Dr. Omondi, you with your patient through this treatment, and you encourage them and advise them. But what are some other examples of patient advocacy that we can do as medical students, as primary healthcare physicians, and even just as like from peer-to-peer basis?
So I think for medical students, it starts from the very basics, actually, of just breast cancer care. And so myself, actually, I'm actually a lecturer at the University of Nairobi at the same time. And so I tell my students, the best thing you'd be able to do for any female who presents to you is to be able to do a breast examination. If you could just examine a breast lump and thereafter teach the lady in front of you how to be able to do it on her own, that would be the best gift you'd probably give that lady, you know, whether she presents to you with an unrelated condition. You know, she could have come because of diabetes. She could have come for a wellness check. She could have come for a pap smear, for example. It becomes a very good entry point, you know, for into the medical system, and make them aware of their own bodies and to be able to pick up if there's a problem. And so for medical students, that would actually be the best thing. The second thing, beyond just being able to do the clinical exam, right? If they're asked for tests, you know, there's always a tendency when you're a medical student, you know, to take much thorough history than most specialists would. And so if you find, you know, any little red flags, please speak it out with your senior resident or with your consultant. Sometimes it could be something as small as, you know, that she's a single mother, you know, maybe she doesn't have support. And so if you pick up those red flags, it becomes easier for the system to be able to advocate for her. It doesn't have to be financial, but it could be, we could be able to walk with them the walk. We could link them up with support groups. And so this is one of the ways a medical student could actually help in the patient advocacy of the patient. And finally, of course, when it comes to patient advocacy within the healthcare system, you must always advocate for the best type of care for your patient. They might not be able to afford it, but they should know that that type of care exists and that whatever you're giving them is not substandard. And I always say, you might not be able to give them the best, but you can definitely try and offer them the best within the limits of the healthcare system that you're practicing.
That's a very interesting point. And I think that's also quite empowering for many breast cancer patients or women who come in and they're not sure how to go about it, because it can be such a detrimental or a shocking factor to be told, yes, you have cancer, but we cannot offer you the treatment that's available. So I think that's quite an important aspect as well, is starting from the ground level. So medical students really do have so much power when it comes to advocating for your patients and to patient advocacy.
Yes, they do. Yes, they do. Medical students have quite a bit of power towards that end. And so they shouldn't feel like they're not empowered to be able to advocate for their patient in the healthcare system. They definitely can.
Definitely. Thanks, Dr. Omondi. Dr. Omondi, moving on to the next question. What advice would you give to the general public when patients are not necessarily visiting the hospitals, they're not necessarily screening opportunities available, but they know that breast cancer might be something that is rife in their community? How would we advocate for patients to seek the treatment, seek help, or I guess even do the basic screening techniques?
So I think just from the very get-go, the first thing would be just encouraging them to increase their healthcare habits. In sub-Saharan Africa, I think we're weak towards this end, towards healthy healthcare seeking habits. And so what has worked for us in our country actually is more, because we're trying to move towards the preventive medicine, which would be much cheaper than the curative, is we have trained more of the health workers all the way down to the primary healthcare workers, so that they're able to push to the community and speak on what, not necessarily shout about breast cancer per se, because when you shout about breast cancer, so then they get scared. But you could talk about, you know, it would be good if you checked your breasts, which is what we do. And this is how you check your breasts. And when we do that, we've actually seen an increase in the screening and in the pickup rate of disease, because then the women are able to come within the system. They are the ones we also pick when we go out into the community and bring them in for screening. But at the very same time, for the women who then pick up healthcare seeking habits that are much healthier, they're able to be advocates within the system. The other thing we do is we also use survivors of breast cancer, and we ask them to go out into the community and advocate for women. And so when they go out, they become a beacon of hope, because they're not dead, they're actually okay, they've been treated, they're going about their lives. And so it becomes very encouraging for the women outside to tell themselves, oh, hey, I could be that in case I have a breast lump. And so when you do that, you do find, even when the women do come into the system, they're not scared, because they've seen survivors at the very tail end who have done well and have been able to go back to work and take care of their families. And so this is how we've been able to encourage screening within the community. And this is how we've also been able to encourage increased diagnosis, and increased clinical adherence and treatment towards breast cancer in my community.
Definitely, that's so important as well. I think having survivors as advocates is such a powerful tool in itself, because it's almost, if this person can go through it, I can go through it if it's ever something that I need to go through. So Dr. Omondi, we spoke a little bit about screening techniques and preventative measures. Could you give us some examples of what we could do almost at home, or what we could, I guess, advocate our friends to do when it comes to screening? So what type of screening is there, if that makes sense?
So when it comes
screening techniques and
okay,
the different screening techniques and methods available.
Okay, thank you, Anya. So when it comes to the screening for breast cancer, so we borrow a lot from the Western world, and especially from Europe. And the guidelines actually state, just generally, for any woman who's above 40 years, they should at least get a mammogram. And for any lady who's at least below 30 years, up to 35 years, should at least get a clinical examination by a clinician, by a doctor or their healthcare practitioner, and should at the very least get an ultrasound. However, beyond this, at least in my country, and probably for most of sub-Saharan Africa, is we do not have enough doctors to be able to care for this. And so it has become imperative for us that any woman who presents for any other reason at all, whether they've come for a pap smear, or they're pregnant, or they've come with any other unrelated disease, that we talk to them about doing a clinical self-breast examination. Remember, I had said this is actually, if you pick it up from your undergraduate level as a medical student, then it becomes almost second guess to you. Next thing you know is you're talking about examination of a breast lump and examination of your breasts. And so once you do that and you examine the lady in front of you, for any woman who's above 40, you should ask them to get for a mammogram. While I do agree that maybe in some countries they might not have widespread machinery to do mammogram, at the very least they could at least do an ultrasound. It is, however, very different from women. When you take a history, you notice that they have a little bit of clustering within the family who've got breast cancer. These particular ones should be referred to a specialist so that they are screened a little bit more differently from just the general population. However, just anecdotal evidence, we've noticed that in sub-Saharan Africa, that the women who present with breast cancer tend to be a lot younger, at least 5 to 7 years younger than the women in the Western world. And so as much as we say, oh, hey, get a mammogram when we are 40, we are advocating for more of the women once they hit 30 years, at least once a year, get an examination done by a healthcare practitioner, get an ultrasound. Once you hit 35, at least make sure you can get a mammogram. And once you do this, once you're in the system, at least you're sure that you've been screened and there's some assurance coming with some clinical background assurance that all is well. And so this is how you would be able to screen. The other thing also is pregnant women, you know, in our setup. There will always be a tendency that pregnant women will think they're breastfeeding. And when they're breastfeeding, they will neglect anything that they think is happening within their breasts. However, we have also been able to talk to the gynecologists in my country through their society and said, examine all women who come to you, examine them, teach them what is different, yeah? And the minute they feel there's something different, they shouldn't be ashamed to come up and ask, can I have an examination? Can I have a second opinion? Can I have a scan going on so that I see what is happening? And we find that when they do this, we are also able to pick up a few of the women who have either just given birth or are pregnant and have breast lumps, which they would have probably ignored and blamed on breastfeeding on pregnancy. So I think this is one of the ways that we're able to screen for breast cancer in our population.
Definitely. I think you've made some really interesting points as well about one thing about the age. I didn't realize that within the African context, it is the younger women that have a more tendency of getting breast cancer than the older ones as compared to the West. So that's a very interesting point. And I think even amongst medical students and in the hospitals now, that should be almost a hallmark finding for us to be more aware of. And another point that I really like that you made is also for patients to become so much more self-empowered about speaking up when there's something that they feel is wrong about their breast or something that is abnormal, because that will be very beneficial in the long term for them, definitely. Thank you so much, Dr. Omondi. So Dr. Omondi, you spoke a little bit about using or having survivors as advocates for breast cancer screening, breast cancer prevention, and different techniques to have them empower community. But what about, is there a stigma in Kenya about breast cancer, or how do you speak to these survivors in order for them to feel empowered and go to the communities and speak about what they've gone through?
Thank you for that question, Anya. And well, what we realized for us is that for the longest time, I think medicine was always, well, this is what you're told and this is what you do. But then once we set up support groups, then we were also able to get feedback as doctors. What are their patient choices, despite what I speak up as a breast surgeon? Do they get to speak up about their choices? And as we formed some of these relationships, and as we started giving them support, one of the ways we were able to do this at Kenyatta National Hospital is we noticed there's a lot of stigma around losing the breast. And this is one of the reasons why some of the women will actually not present on time for treatment. And we realized that while we might not be able to get access to prosthesis, which they would be able to put inside their bras and make them feel like they still are breasts, there were different support groups that came up and they were able to crochet some of this or prosthesis. And there are also other support groups that came up and said, you know, you will lose your hair, but we could make a wig and make you feel the same again. There are other women who also came up and said that they would be able to put makeup on them. And so once we realized that in doing these small things, they were able to integrate better back into society and into their families after treatment, they felt that the treatment hadn't really changed their personality per se. It might have changed them physically, but they were able to alter the physical part of them, but they were still the very same person before they started treatment. And in doing this, we were able to reduce the stigma. The second thing we did is that as more breast surgeons got trained, we were able to say, you know, a breast cancer diagnosis does not always mean that you lose your breast. There's newer techniques now, you know. what we call breast conserving surgery. Yeah, we are now able to give chemotherapy for some cases before surgery, and then once there's response to your chemotherapy, then we're able to do surgery without necessarily losing your whole breast. And the more we spoke about these different options that were given to these women, we noticed that the survivors then became advocates for the very same things. Because the truth is, when it comes from a doctor, it almost, well, at least in Africa, it sounds like, well, you got to do this because that's what the doctor said. But now we were telling them, well, there's what I'm saying, but then there's what do you want from me, and how do we make your work better in your treatment? And so we realized once there was a bit of give and take, then they became advocates of the very system that we thought was not offering them what they needed. That was how we were able to get the survivors to speak.
That's so important. And I think I'm honestly blown away, and I'm really impressed with the idea of the support services. And then again, the empowering the patient themselves to take ownership of, their own, how do we get treatment? How do we take this so that I don't lose myself? Because I think, so right now I'm actually, I'm rotating through surgery. And on Tuesday, we had a double mastectomy patient. And it's very traumatic, because even like from a medical student's perspective, you sit there and you're like, how do you empower this woman to feel like she can still be herself? Because you can see the emotional drain, the mental, the physical, and everything. But this idea of having support groups that then can empower one another is so important. Which brings me to my next question. So you're currently based in Kenya, and you're at the Kenyatta National Hospital. So can you tell us a little bit about the support services that are available and within Kenya, and as well if you know of any communities online or something more national that we could, I guess, refer patients to or let them look into, or even just medical students or physicians to refer patients to?
Thank you for that question, Anya. So in my country, so Kenyatta National Hospital is actually the largest national referral hospital in the country. It is also a teaching hospital. It's able to cater to about 3,000 patients because of the highly specialized services that they're able to offer to the country. It is also the largest hospital in Eastern Africa. With this in the background, so we do have a breast unit that has been able to grow in leaps and bounds, especially over the last 7 years. So right now, as we speak, we are 3 breast surgeons in the unit. However, what we do, because we tend to see a lot of the breast cancers that will present within the larger region, most specifically because the hospital is actually the national hospital and the teaching hospital. So most of the patients would want to come to the hospital for that very reason. So we run our clinic once a week. We see on average, 45 to about 55 patients on this breast clinic day. And 95% of these patients will actually be because of malignancy. That is actually the bulk of our patients. So what did we do so that we would be able to advocate for the patients in the system? The American College of Cancer Society actually funded a navigation program within the hospital, because the hospital is quite expansive. And so we put up 3 levels of navigation. There's the physical navigation, the psychosocial navigation, and the financial navigation route. So the physical, so actually the navigation team beyond the doctors is actually run by a team of 15, where you'll have the patient navigators, counselors, and cancer care nurses. Secondly, the next thing we did beyond that is we always ensure that within our clinic, we have at least 2 nurses on the ground and 1 counselor and at least 2 patient navigators. So what did this do for us? Once I see the patient and I either suspect or I have made a diagnosis of the cancer, the next thing we did is we registered all these patients in our database. and we took their details down. And what we did is we followed them up with a phone call, you know. So Marilynn, how are you? How is it going? How are you doing? Do you need any help from us? And we realized most of the patients were actually shocked that somebody was following them up. The next thing we did is, because the hospital is quite expansive, we labeled the areas that give cancer care. And so we actually put footsteps along the path of the hospital, and we told the patients that if you're going to this point associated with this cancer care, so because we're serviced by different other departments, oncology, pathology, nutrition, diagnostics and imaging, we actually put footpaths within the hospital, and we told them, if you just follow this, when you get there, you're going to get help. And what we did for some particular patients, because it can be quite overwhelming to be told that you have a diagnosis of breast cancer, is that once we made the diagnosis and we took their names down within the system, what we did was the patient's navigators, would physically walk with them to the different points of cancer care. So if it's learning where the pay points are, learning where oncology is, learning where diagnosis and imaging, learning where diagnostic imaging is became important for us. And then of course comes the psychosocial aspect of that. Psychosocial is, so we've told you there's a diagnosis. You know where the physical points of care are within the hospital. But what about the psychosocial parts? Are you able to come for treatment? Are you able to buy food? Are you able to do this different type of tests? And so we are able to stratify the patients and know what type of support to give. And then when it comes to the financial aspect, the next thing we were able to do through the navigation system is, once you identify patients who will struggle financially, we have a social insurance fund, which we call the National Hospital Insurance Fund, that is run by the government of Kenya. And we were able to get funding for patients through this, where they would be registered into the fund and they would be paid for, rather than getting their treatment paid, but they would be paid for, so that the fund caters towards their treatment within the hospital. And for anything that they are not able to do, we would link them up with other different kinds of organizations. We, for example, have the Faraja Trust, we have the Kenya Cancer Society groups, and very many others that are able to help us in this. And we realize that in the eventual step down, simple things like, even for the patients who maybe physically might not be able to get to the pay point, psychosocial, we have a problem, financial, we have a problem. Some of these patients, we actually have funding towards giving them accommodation near the hospital. And so they're able to, they're within reach of treatment. And so the clinical adherence actually improved just by doing this.
That's really impressive to see that the hospital has facilities and this navigation system in place. How long normally, because I'm assuming this didn't take an overnight thing, but it seems like there's a lot of it's a multifactorial platform. So how long normally does it take to set something up like this? And what advice can you give to the rest of us who are, I guess, because I'm in a tertiary hospital at the moment, like, we don't necessarily have things like this in place. So what is the steps, or what kind of advice could you give us so that we could start to implement something like this and use Kenyatta National Hospital as a role model?
Well, it took us about a year of just getting through the cogs in the system. And but once the impact of the navigation was seen, and through the funding we got from the American Cancer Care Society, the hospital administration was able to see the impact, and so they gave support towards it. But what you don't really need a lot of people. You just need the cancer caregivers to just come together. And what we did, we came together with the oncologists and the pathologists and the radiologists within the hospital, and with the nursing cancer care team. And we just put up a small team. And we said that as long as you come to this clinic, well, this is how things go. And we started really small. But then as demand grew, so did the support. And so that is how we were able to, so to speak, get such a widespread coverage within the hospital. But I think some of the simple ways you could start, which is what we started, is you just need about 2 or 3 people in the oncology clinic, actually, because that is, you know, breast cancer is just a very small part of oncology. But if you could just centralize it first within oncology and just say, you know, we're just going to put signs to show this is how you get to the oncology clinic. We're just going to put footsteps of this color so that when they come through the gates, for the patients who necessarily might not know how to read, or whenever they reach the hospital, they simply get overwhelmed. All they need to remember is, I just need to follow the purple footsteps on the floor and I'm gonna get to my clinic. Yeah. And that was how we actually started. We actually just started with patient navigation, physical. And then once we did that, we said, okay, now let's get the people to actually adhere to their treatment. So once we started realizing the gaps in the psychosocial, most of it will actually be the socioeconomic status. And once we realize that, it's very easy to approach a lot of the people who are funding. And so, for example, we were previously where some of our donors would actually say, for example, I'm going to give treatment towards patient X. We told them, well, now instead of giving patient X all the money, you could give towards a fund that will pay for the social health insurance, or you could give towards a fund, for example, that is going to help towards imaging, towards doing mammograms, towards ultrasounds, or you could give towards a fund that will go towards supporting them in their nutrition, towards supporting them in their accommodation. And once we did that, we found the people who are funding us actually thought it was a much better idea. Rather than just funding one patient, their money was now funding a whole other program that's much more sustainable than taking care of one treatment plan for one patient. So you just really need to start small. And then from there, it kind of just grows a life on its own. Of course, with you guys at the front of the wheel and, you know, driving the car.
Definitely. I think that's a very important point as well, because so many times I've also wanted, you know, I would be like, oh, I want to have a whole facility going on. But again, you have to start small and then let it grow slowly. And I mean, if it's an important cause like this, then definitely you get the momentum and you get the funding, you get the support. And I think that's quite an important message as well, a takeaway message from today, is even just start small, even if it's medical students, because I think even when we think about medical students in the hospital, it's almost like, well, all you do is history taking. But then earlier you've mentioned that history taking can be such an important aspect in patient care, especially when it comes to helping patients advocate for themselves. So I think that's quite an interesting point as well. I think that your hospital you're such a big blessing to your hospital, Dr. Omondi. I think I'm just thinking about my hospital and how your advice now would definitely benefit in creating a more patient-centered approach, but then also creating a bigger opportunity for funding to be available for a bigger populace than just the one patient, for example. So I know that we're still talking a little bit about patient advocacy and care for how can we as medical students, how can we as healthcare professionals help our patients. But for the general public, what are some important signs and symptoms that we can keep an eye out for, I guess, for just our audience right now? What are the symptoms of breast cancer or a breast lump that would be of concern?
So the first thing I think is, first, actually, you shouldn't have lumps within your breasts. I think that's the first message. But then it doesn't mean that all lumps are cancerous, but you should definitely get them checked. Having a painless lump, I think, just, you know, a lump that's not painless is a bit of a red flag. Having a nipple discharge, especially if it's clear or bloody, is a red flag. Having skin changes, you know, looking like there's a rash, looking like there's an infection over it, is a bit of a red flag, you know. Having nipple retraction, having your nipple pulling is a red flag. The other thing is another red flag that she could have that would not necessarily be straight out cancer in itself, would be having a growth that seems to grow slowly over time. Yeah, getting some hard fixation of a growth on your chest, having a unilateral arm swelling. Yeah, that is not normal. And then, you know, just generally also as women, you know, some patients will tell you that they're not sure, that they feel like there's a lump, but they've come for a checkup. Those ones definitely should get checked. But I think the take-home message here is, you know, having what looks like a skin infection, and you know it just started off on its own, having a breast lump that seems to be growing over time, it's painless, and having a discharge. Those are some of the red flags that you should worry about. You could have some skin changes that not necessarily look like an infection, you know? So if the skin starts changing color or starts giving the appearance of like an orange, you know, what we call the pseudo-orange, I think it's very important that you come in for a checkup, okay? And I always tell my medical students, which I also tell them to go out and tell other women, you know, oh, hey, colored discharges are good, you know, because when you have an abscess, it's normally colored, you know, it's yellow, it's green. But the minute you see a discharge that is clear or bloody, that definitely needs to be investigated, because there might be an underlying issue, so to speak, that could actually lead to diagnosis of breast cancer. So that is very important for patients to know as red flags.
Definitely, I think that's very important. And I actually didn't really think about the colored discharges versus the bloody and clear ones. So that's also, I'll make that an extra point in my exam, and maybe I'll get extra marks, but if something worth looking into. So Dr. Omondi, you've been based at the Kenyatta National Hospital for many years?
Yes.
Okay. Can you tell us about some of your experiences, some of the highlights that you found working there, the impact of changes that you've made, and any challenges that you faced when it comes with patient care at your hospital?
So first, like I've mentioned, it is the largest national teaching and referral hospital. I have been there for about 10 years now, 5 of which have been as a consultant. And I think one of the biggest take-homes we can take is that we've seen growth of the breast unit. And one of the biggest successes we've had in advocating for our patients is we've actually been able to start a multidisciplinary team discussion that has been able to link up the other departments and just be able to discuss patients with breast cancer. And in doing that, we've found just beyond learning from other services like oncology and radiology, and even just listening from the cancer caregivers, is our patients actually end up having much better treatment, and there's much better connections within the department. And we've seen that for breast surgeons and for oncologists and other breast cancer caregivers alike, we've actually seen a confidence boost that despite the challenges we would have within the system, we can see that the wheels are moving. The wheels are moving, and patients are speaking about the work that we do. And that in itself gives us, you know, some happiness that this is what we're doing. And currently, our multidisciplinary breast cancer team is actually one of the biggest in the country. And, you know, I think COVID really helps us, because previously we were doing it physically, but then now we moved online. And in doing online, we have a lot of the surgeons who are now able to bring their cases on board from different regions of the country, and we're able to discuss and give them, you know, a plan that they're able to work with. They're not able to implement that plan, then we've actually kind of straightened out the referral process through the system. I think, though, one of the things that I think we would still be able to improve on, though, of course, this will change now that we have some form of government support, would be the referral system, which I think speaks a lot for most sub-Saharan countries, unlike in the West, where you have, if a patient shows up to the very first clinician and they're either need to be screened or they're thought to be suspected to have breast cancer, we do not exactly have a link that would forward the patient through the system. So most of it is actually patient-centered, but we are hoping that it will be clinician-centered, healthcare practitioner-centered, where if I get a patient, then I know I should be able to push them through the system rather than waiting for the patient. Because, you know, most of our patients, they tend to say, well, let me go back home, let me sort out my issues, and then I'll be back to sort this. But remember, it's because of also the beliefs, you know, the African beliefs that surround cancer, so to speak. And so some of them, they were quite early in the system, but then by the time they present to us in the National Referral Hospital, it's quite late to just, you know, do the less expensive treatments. And now we're talking of the more expensive treatments. But all in all, we've seen clinical adherence grow. We've seen our clinic grow. You know, previously we were seeing 40 patients on average. Now we are seeing 50 to 60 on average. We are having most of them stay on their treatment. We're having most of them give us feedback. And we've also had a lot of the partners able to, you know, fund the other aspects of treatment beyond the cancer diagnosis. And I think that has been one of our growths. And what we've also been able to do as a breast unit, and we've also been able to impact outside our specialties, we've been able to show, you know, breast cancer is beyond just doing a mastectomy. There's a whole lot to it. There's reconstructive surgery that can be offered. Breast conserving surgery needs some form of reconstruction. And now we're saying that breast cancer does not mean that you lose your breast. And I think that has been one of the biggest gains for the breast surgery in my country and in Kenyatta National Hospital.
Definitely. Thank you so much, Dr. Omondi, for taking the time out this afternoon. We're rounding up to the hours, so I haven't seen any questions in the Q&A. If there's any participants or any members that would like to ask anything, please go ahead now. But I see there are some comments. So I see Dr. Asambang also speaks a little bit about these color coordinations of the footsteps and how it's a good idea. And she's personally seen that also in the emergency rooms and in the ER. So that's quite an interesting thing. I don't actually have that in my hospital. So maybe that's something I should speak to them about doing, because it seems like it's a good idea and it seems very important. But I definitely love the conversation that we had here today. I love how you advocate for medical students as well, to encourage patients to do the self-screening and teach your patients about doing the breast exam, take thorough history takings, but then also being able to speak to your seniors and your consultants about it, and also just advocate for the best care for your patient. I think that is such an important part of that information, because so many times as well, we see, and unfortunately, especially in low resource countries and hospitals, where patients come to the hospital and they know automatically they might not get the best care because it's a low resource setting. So it's not okay, guys, to just give substandard treatment, but push for the best of what is possible. I also really like that you've mentioned the starting small and then growing and making it get bigger and bigger, and you're such a great example of how that has happened. And I think that has inspired me, and I'm sure it's inspired many of the other members or the participants that have joined us today. And I think you really tapped into the important aspects like the psychosocial, and then making sure that even our patients have the ability to have money or for food, not only for treatment, but definitely to see that it's very interesting and very important conversation that we've had today. So from my side, Dr. Omondi, if there's any take-home message that you'd like to give as well, please go ahead. But from my side, I'd just like to say thank you so much for taking the time out this afternoon. And I might be sending you an email just to get your advice about how to implement something like this at our hospital, because I think you've got very interesting points. So thank you so much.
Thank you so much, Anya and Dr. Asombang, for having me on this platform. I'm always happy to stand up as a patient advocate and with my passion for breast cancer care, simply because working in a low middle income resource, the truth is cancer care can corrupt even the richest that there are. It can corrupt even the richest that there are. And just because we work in a low resource setting does not mean that you do not give the best of care. I think you should be able to put everything on the table because, well, especially I think for us in our country, sometimes we do have patients who will choose not to go to the private sector because they feel like they're going to save some money here. So some of the patients will actually surprise you with what they would like to have on the table. But beyond that, I think we're also moving towards a population that is much more enlightened. And just because they might not be able to get it, they would definitely ask about it. And I think it would be good if you inform them, and that is the informed choice that they make, that you should be able to offer them the very same that they would wish to have. My take-home message, I think, is if you advocate for your patient beyond the diseases that they are presenting to you with, beyond breast cancer in itself, I think the returns you have as a physician are enormous, and your practice is much more satisfying. Thank you.
Thank you. Thank you so much, Dr. Omondi. First of all, I think as Anya also pointed, we are on behalf of Poor Hair and a personal note, absolutely grateful that you could make it today. We know obviously as a surgeon, your schedule can be super busy. Your weekends are precious. And so, we are grateful that you took the time out to share your knowledge, to share experience, because it provides, from a mentorship perspective, it provides support and inspiration for our mentees. When you listen to the journey of becoming a surgeon, it's rather intense. And then just to top that, and just mentioning as a woman, there is that extra barrier, not that you put upon yourself, but sort of that society puts upon you. And then the patient advocacy thing is very, very important. As medical students, they play a critical role because the medical student may be the first person that sees the patient, and they get a detailed history. So just, this information also helps them in addition to the normal lectures that they get. This information helps them in terms of navigating that. You're the first contact. And then, for, us, the more, senior consultants, this is also helpful because it's a teaching opportunity. And then for the patients watching and, back to the medical consultants, we always have to remember that, any cancer diagnosis is, like you pointed out, it's mentally exhausting. And I liked the patient navigation system. And I think that's something we may be lacking in most of our African countries where, you have that psychosocial component, because that psychosocial component plays a big role in the patient accepting and understanding the treatment that you're offering. If a patient is not understanding what it is you've explained, you may mislabel them as the difficult, but maybe you as the doctor just didn't do a good job explaining what it is that the patient has in terms of options. I loved your multidisciplinary approach. I think that's extremely important. When we take care of patients, it's not like me, who's taking care of patients, but there's other people who are involved in that, in that taking care of the patient. And, when you mentioned the footsteps going, to the breast cancer unit, automatically, honestly, I just thought, oh, wow, I've always seen that in the emergency room. There's always like color codes to triage, to trauma, but I never thought of it from, I looked at them like, all right, how do I get to trauma? Follow the purple line. But I liked how you also explained if someone is not necessarily able to read, but then, it's known that the purple, pink footsteps or whatever it is will lead to the breast cancer unit. Yes, you can ask people questions, but at least you also kind of have that when you get lost in the hallway, turn and just follow the pink footsteps. And I've seen it in the children's hospital, but I never really thought of it beyond, oh, this looks kind of cute and you follow this. So I really like that point that you've made. And, all the questions that have come in, thank you. And to those who are watching, glad you could make it today. This has been recorded. It'll be uploaded to the YouTube page since not everyone has Facebook. We do have another session coming up at the end of the month, as mentioned, and there's a comment in the chat, Dr. Omondi, for your amazing responses. And I would have to agree, your responses were clear. There wasn't hesitation. What did she say? What does she mean? You know what I mean? So you clearly defined what it is. Patient navigation involves this. Your symptoms of breast cancer. I liked how you differentiated the discharge that comes out of the breast. I liked how you explained the peau d'orange in terms of, the orange peel, some of the symptoms and stuff, or signs that one can see. You explained it with such clarity, such that, if there's anyone out there who even has doubt after listening to this, you can always go back and just kind of listen for again. And, Anya made a note, we were sort of focused on patient advocacy, but those points about the clinical symptoms, how do you get screened, what age, are just as important in that patient advocacy, because you'd be able to tell the patient this is what they need. And the important point about, things are unique within your own country. So the age of screening and all that kind of stuff may also be unique in terms of guidelines for that country. And on that note, I think we've done pretty well with the time. We're always trying to be respectful of our speaker's time. So Dr. Omondi, on behalf of COHER, on a personal note, thank you. Truly appreciate your time and the knowledge that you've shared with us today.
Thank you. It was my pleasure. Thank you so much.
Yeah, and Anya, thank you so much as always on being the COHER Scholar Moderator. Appreciate some of those questions that you posed as well. And to the audience, those in the webinar and those who are watching live on Facebook, good morning, good afternoon, good evening. Everyone have a fantastic day. Watch our social media pages for updates regarding our next speaker. As mentioned, Dr. Marilynn Omondi. It's actually interesting. I think this month, okay, yeah, and I was going to say all speakers, I know all speakers have been female, but then I was going to say all speakers have been Kenyan, but I realized the first one was from Zambia, and then we've had, Kenya taken over. In the past, we've also had other speakers from Kenya. Everyone by now should know our famous neurosurgeon, Dr. Beverly Chesarum. But we've had like fantastic speakers from Kenya. So anyone who's out there thinking of where to go train and you're like not sure, maybe you should also consider looking at Kenya and seeing what it is that they have in Kenya if a program is not available in your country. All right, on that note, thank you everyone. Have a fantastic day, and we'll catch up again in about a week or so. Thank you so much. Thank you, Dr. Omondi. Good day to all. All right.